Hello, everyone. My name is Shadi Yaghi. I'm a vascular neurologist at Brown University, and I'm the writing group chair of the scientific statement, Treatment and Outcome of Cervical Artery Dissection in Adults. One of the topics that's covered also in the scientific statement is about the risk of recurrent dissection. This is an important question that comes up in clinical practice, often by patients asking about the risk of recurrent dissection. Luckily, the risk of recurrent dissection is low. It's about 1% per year, but this seems higher in the first few months after diagnosis. Patients who are under the age of 50 years and those with fibromuscular dysplasia have a higher risk of recurrent dissection. We would generally consider avoiding activities associated with dissection risk, any activity that would potentially increase the risk associated with neck injury. And we list some of these in the manuscript. These activities are avoided for the first 6 months from section diagnosis and longer in patients with recurrent dissection or those at a high risk of recurrent dissection. Another imaging finding that's sometimes encountered in patients with cervical artery dissection is a pseudoaneurysm. Cervical artery pseudoaneurysms can be present at the time of dissection or sometimes diagnosed on follow up imaging. They rarely cause symptoms, and the risk of rupture of a cervical artery dissecting pseudoaneurysm it's extremely low, and thus most can be observed without endovascular treatment. Endovascular treatment can be considered in those with symptoms related to compression of nearby structures, such as sometimes dissecting aneurysms in the neck can cause cranial nerve deficits, and if these are causing compressive symptoms, treatment can be considered. Mind you that this scientific statement does not discuss intracranial pseudoaneurysms, and the treatment approach for these patients is different and not covered in this scientific statement.